So next we're going to assess the patient's airway and breathing. If the patient is unconscious, we use the head tilt chin lift only if we don't suspect any spinal trauma. All right, so if we don't suspect any trauma at all, we can use the head tilt chin lift. If we do, we use the jaw thrust. You guys know what those look like? Okay. Place an ear over the patient's nose and mouth and watch the chest for movement. So we kind of do the whole thing you guys learned in the BLS program with CPR. So you put your ear down, you try to look, listen, feel for breathing. Assess circulation. Where do we want to assess circulation? Carotid pulse, and a lot of people like doing a carotid and a radial at the same time. So that way you can kind of get a feel for what their blood pressure is. If their blood pressure is really low, you're not going to be able to feel the radial, but you should still be able to feel the carotid. If the patient is not breathing, check for that carotid pulse on either side of the neck. The only thing I have to say about this is do not place your hand over the trachea. Always do it on the side that you are on. If there's no pulse, call for assistance and begin CPR. And everybody in here is a BLS card holder? All right, great. So then we check for severe bleeding. Severe bleeding means you're seeing large pools of blood. You can see actual arterial bleeding or venous bleeding. Those are severe cases of bleeding. Like it says here, check for profuse spurting or rapidly flowing blood. It may be necessary to attempt to slow the bleeding at the same time the patient's breathing is being assessed. So this kind of depends on how many people you have on scene. If you have a bunch of people on scene, both these things can be done at the same time. If it's just you and you notice rapidly profuse bleeding, if you see it pulsating, squirting out, you know the person has a pulse, and I would actually just try to control the bleeding first. But if not, you can attempt to control the bleeding and then at the same time check to see if they're breathing, if that's possible. Determine the urgency of patient transport and relay the information to EMS responders. All right, so you're gonna sit there and say, does this patient need to be transported right away? A lot of times the answer to them be yes, but if you have multiple patients, that's when you kind of have to start playing triage, and you're gonna have to figure out which one needs to be transported first. And you also need to let EMS know how many ambulances you will need. So we kind of already covered this. Everybody here is a BLS card holder. So external bleeding. First, we're going to start big and kind of move small. So arterial bleeding. Bright red spurting blood from any artery. This is the most serious type of bleeding. All right. So if you see really bright red blood, you know it's arterial, and if it's spurting, you know it's coming from an artery as well. All right. Next is going to be venous. Dark red blood flowing steadily from a vein. Can range from minor to serious. So this could range from, you might have nicked your hand and nicked a vein, and it could be bleeding. Those are pretty easy to control with just some direct pressure. Or you could hit a large vein in your leg, and that's actually going to be a pretty serious bleed. So that's what it means by really mild all the way up to severe. And the last is going to be capillary. All right, this is just the nick you get whenever you're shaving your face or paper cuts, stuff like that. Minor scrapes and shallow cuts are going to be causing this. All right, what do we do first when we're trying to control bleeding?
Direct pressure.
So direct pressure, okay. So if he has a bleed on his arm right here, we're going to come up. Put a gloved hand, so remember BSI scene safety, so you always have a gloved hand. Put a gloved hand on that cut, put some direct pressure on it, and hopefully with that direct pressure alone, that the bleeding will be controlled. If the bleeding is mild, you could even kind of take your time with it a little bit, grab a 4x4, 2x2, put it on there with some pressure, and then get some Coban, clean, Ace wrap, whatever you'd like to use, and wrap it up then. That should be good enough to control bleeding. So the next step is going to be elevation. So let's say I have a cut on my wrist, you put direct pressure on it, it does not work. The good thing about the arms is it can be easily raised above the head. All right, so elevation, anything above the heart is gonna help slow that bleeding down. So maybe with some direct pressure and elevation, the bleeding can be controlled. The third is going to be pressure points. So if elevation, direct pressure, elevation did not work, we're going to use a pressure point. Now pressure points do help a little bit. They're not as recommended as the other three. So pressure point is going to be anywhere where the artery kind of comes up close to the skin. So the way I like to think of it is places where you can feel pulse. So you have your brachial, your radial, your femorals. There's one in the popliteal region, so around the knee, and then to the foot. They're not as useful, like I said, but they can come in handy. A lot of people like to kneel on the femoral, so if you're going in and you're going to have to use a tourniquet because there's some arterial bleeding, one good tool or technique is to come in, kneel where you think the femoral artery is going to be, so near the groin. You can kneel on that while you're getting your tourniquet ready. That's just a handy use for pressure point. Then that one, the last one is going to be tourniquet, okay? Like it says up here, tourniquet should only be used as a last resort, all right? Why would it be a last resort?
Can cause damage to tissue perfusion.
Yeah, so tissue perfusion. So you put the tourniquet on. If you do it tight enough and you do it correctly, that the rest of the leg or the rest of the arm or wherever you applied it could go without blood. So even though you are stopping the bleeding, which is what we want to do, you're also possibly causing damage from not allowing blood to be circulated through that extremity. Yeah, so it could result in the loss of a limb. That's another reason why whenever we do put tourniquets on, we always write somewhere obvious that they do have a tourniquet on. So a lot of people like to do foreheads, TQ for tourniquet, and then the time. So the doctor knows the time it was placed. That way he knows how long the tourniquet has been on, so he can start to re-perfuse that leg.
Outside of placing the tourniquet or undoing the tourniquet, how would one reperfuse the leg? Or
That's what it is. So eventually, after a while, that where it's bleeding from should clot up, and it is mainly loosening the tourniquet a little bit at a time. And only doctors should be doing this. We shouldn't be doing it in the field. So you just loosen it a little bit at a time, and just see if there's any blood. And the other thing about tourniquets is, if you put one tourniquet on, bleeding is still not controlled, we put another tourniquet on. All right. So you can always add more tourniquets. You never want to take them off though. So once you have one on and you want to add another one, you never take that one off, okay? The other thing is, how high do we put the tourniquet above the wound?
2 to 4 inches.
2 to 4 inches, okay? Now, in certain scenarios, it might be hard to tell where the wound is, especially if somebody's wearing clothes and you're just trying to get it on as soon as possible. You don't have enough time to cut the clothes off to see where the wound is. We always just say, go as high as possible, okay? If you just see a bunch of blood or you see spurting blood coming out of my leg and it's kind of hard to tell, okay, where's this wound at? Just put the tourniquet up as high as possible, all right? So we're moving on to internal bleeding. Some symptoms of internal bleeding. So this is going to be something that the patient is feeling, okay? They're probably going to have some pain with it as well, depending on if there's trauma from it. You can't have internal bleeding without any trauma. The example would be ulcers. in the stomach or in the intestines. But some symptoms they could be feeling is the patient might feel weak, they may feel cold, thirsty, and they may feel anxious or restless. Some signs are going to be, signs are going to be what we can see, what we're looking at the patient, finding out. They might be pale, cool, clammy, so they might be showing some signs of shock. Rapid, weak pulse. And if you can get really detailed with this, you can get dilated pupils, falling blood pressure, altered level of conscious. A big one is whenever you're doing your assessment, palpating the stomach. All right, if they have an internal bleed in the abdomen, you're going to start feeling firm, rigid areas, or the stomach might actually look like it's protruding a little bit. All right, here are a bunch of other signs. Wounds that have penetrated the skull. Okay, so we start thinking about brain bleeds with that. Blood in the ears and nose. What have we learned from bleeding in the ears and nose?
Look for CSF.
So CSF, all right, and battle signs. Blood and vomit, that could be, like I said earlier, from ulcers in the stomach. Bruises on the neck, chest, wounds that have penetrated the chest. If there's a gunshot wound, something like that, and you only see one wound going in, no wound going out, that means the bullet probably bounced around a little bit in there. So don't just suspect if you get shot here that that's where the only damage is at. You can get shot here, the bullet can bounce around, hitting bones and stuff, and you could have internal bleeding all over. Bruises to the abdomen, tenderness, bleeding from the rectum or vagina, and fractures. All right, treatment is going to be call for more advanced care. All right, who's ultimately going to be the one taking care of this?
The physician, doctor.
A physician, so call for more care if you can. Perform the primary assessment, like it said before. Keep the patient lying still. All right, you don't want to move them around. You don't want to cause any more internal damage. Loosen restrictive clothing. You guys are probably going to do this anyways, cutting some clothes off. But if they are still wearing belts, really tight pants or jackets or stuff like that, just cut those off. Treat for shock. How do we treat for shock?
Supine, warm, oxygen.
Supine, warm, oxygen, and lastly, don't give anything by mouth, but transport ASAP. All right. The biggest thing on here, I would say, is transport. Like we said, a physician's going to be the one taking care of internal bleeding. We aren't, so we need to get them to the hospital as fast as we can. And that's it. Does anybody have any questions? No.
Can we see one flash real quick?
Yeah. So who wants to come up here? Okay. So there's a couple different types of tourniquets. This is going to be the one that you guys will mostly see. This is a cat tourniquet.
And when you said you applied multiple, it doesn't stop. Do you apply the second one higher than the original one, I guess?
It depends on
Where there's more space.
Yeah, where there's more space. So like I said before, if you applied it high up in the first place, you might not be able to get it. So you would go underneath. But let's say you applied it right here,
Yeah.
then you could always go a little bit higher or lower depending on where it's at.
Gotcha.
And another rule of thumb I like to go by is stick to where there's areas of only one bone. So if it's in your arm or in the lower leg, lower extremity, stick to where you're putting the tourniquet on the humerus and the femoral femur. Because the artery can sometimes run in between two bones and you won't be able to tighten it down good enough. So you take your loop, you put it on. With these, you have to loop it back through. Try to get it as tight as you can. And you want to get as much Velcro coverage as you can as well. And then from here, you just start twisting, okay? and then you twist until you notice the bleeding stops. And then these hooks are there for a reason. They want you to hook it in there so then it can't twirl undone. You add the Velcro through, place that, and it even says right here time, so that's where you put your time. All right. Any other questions? Good. All right. We're gonna take the test now.